Hello, I am Tae-Kyung and I am a breast surgeon at Seoul St. Mary's Hospital, which is in Seoul, Korea. We are going to meet our Dr. Olivia Pagani, and we are going to talk about young breast cancer patients, especially the issue of fertility preservation, pregnancy, and delivery in these patients. This is a quite important issue as the age of marriage and pregnancy keeps going up. So good morning, Dr. Pagani. Could you please introduce yourself for the audience first?
Yeah, I'm Olivia Pagani. I'm a medical oncologist. As mentioned, one of my key fields of interest in breast cancer are young patients. I am the chair of the Breast Cancer in Young Women Consensus Conference, which is held, supported and wanted by the European School of Oncology every 2 years, and we had the GBCC last October, unfortunately virtually. And Korea was a very important participant in this last BCY. So I'm very glad to be here and to discuss with you the specific issue of young breast cancer patients.
Thank you very much. I'll start with the questions. So our topic is one of your major research interests in breast cancer, and it also is really important in Korea because we have a quite high proportion of young breast cancers here. Could you please just briefly introduce the positive trial, the protocol a little briefly, so for the audience, please?
Yes. And Korea participated to the positive trial, so we are very proud of that. So because one of the issues, then I will talk about the trial, but I think that what I really wanted from the beginning is that the trial should have been representative of worldwide patients and not just Western countries. So we worked a lot to open up the trial eligibility and the trial participation to as many countries as possible. It was really difficult because it is not a sponsored trial. Because no drug company is interested in pregnancy. There is no drug. And so it was really very, very, very difficult. And all the staff did a wonderful work. And we had to find sponsor and we had to find funding outside of drug companies. So it was really, and it is still really very challenging. But we were very successful. And this is, I think, the demonstration that this is really an issue which is very in the heart of many investigators and patients, because the accrual went very fast. We were able to accrue 517 women. And the trial is really very practical, very empiric. It was, of course, not possible to randomize patients to get pregnant or not. So we really designed a trial, and it took a couple of years to put everyone's idea together. And so it's, I think it was really a very important work, and the trial, so it's very empiric. Of course, the major eligibility criteria is that women have a pregnancy desire. So we do not force or we do not induce women to have a pregnancy desire. And so at the end, the design is that women should have taken at least 18 months of endocrine therapy, from tamoxifen to LHRH plus exemestane, because this is the shortest duration which has been demonstrated to be effective. And up to 36 months. And then they can have a 2 years stop to be able to conceive, and even if they want to breastfeed. And the 2 years interval, and this gets back on what I said before, was, for example, to be able for Jewish women to have 2 pregnancies. Because for them, one is not enough. Because in their culture, The more you have, the better it is. So we did the calculation that in 2 years, you can be able to have 2 pregnancies. So, you know, we had to accommodate to a lot of this kind of requests from many countries. And then they need, and this is the most difficult part, and we will see, they need to resume endocrine therapies to finish up the 5 years or 10 years, whatever was the planning at the beginning. And then we study also the offspring, the ability to get pregnant, so the fertility issues, the offspring issues, and then a lot of translational, so circulating tumor cells, a lot of gynecological issues. So we try to put as much as possible from a scientific point of view in this trial, and we will see. We are really very excited too for the results.
Yeah, so I'm really excited, and I believe that all the audience will be really excited about the results. But so when do you expect to have any preliminary results? We are really eagerly waiting for them, actually.
I think that it will take for the first, it depends, because the endpoint of the study is breast cancer-free interval. So it depends, of course, on the number and when they will occur. So far, we had, of course, the data monitoring committee, which is monitoring the trial. There is no safety issue, because another important thing is that we do not want to, if a pregnancy protects against breast cancer, because this was the initial idea. There are data that women who become pregnant after breast cancer can be protected from a relapse. But to have this kind of question answered, you would have need thousands of patients and a randomized trial. So we decided to have the issue looked at the other way around. So is safe to interrupt endocrine therapy to become a mother? So this is the question. Yeah. And so I think the first data will be available in 2-3 years, but we are looking at the characteristics of the patients who were enrolled. So a paper is almost ready to look at the differences from Western to Eastern countries. What kind of patients have been enrolled according to stage, to any characteristics of the disease, if they were patients who had no children, or patients who had already children. So we are looking at the data because we think it's important to try to have a picture of the population of women who entered the trial, and also the population of investigators, because this is another very important topic. Many breast cancer specialists still discourage young women to get pregnant after the disease. So we want, and this is very tough because many patients have to discuss with their physicians, and this is a source of stress, and this is not good. So physicians need to know that it is safe. What we know so far is that it is safe, but we had no prospective data. So the positive trial will provide physicians prospective data. But the evidence, the retrospective evidence, is quite solid. So we think that physicians should know that. And so we decided to write this paper to be able to give a picture of this kind of population to everyone.
In the trial, spontaneous pregnancy and pregnancy through IVF are both permitted. So would you think an IVF procedure would affect the patient's prognosis regarding breast cancer? And also, during the procedure, the patient is exposed in a high estrogen level. So how many times do you think it would be possible to get an IVF procedure?
Okay, I think that the data on IVF is quite solid. So we have, and there is a scientific background. And it's the same reason why we think that pregnancy can be protective. Because a boost of estrogens can be therapeutic. You are too much young to know that in the past we were treating breast cancer with high dose estrogens. Okay. And so there are the preclinical data supporting this kind of approach. That's why we think that the pregnancy is not only safe, but could be protective. We will see. But then there are data that stimulating for a short period of time the ovaries to be able to get pregnant is safe. And the recent procedures do combine aromatase inhibitors during IVF. And so there are data that this is more effective than hormones alone. And this is a sort of protection as well. So there are now accumulating data that this is feasible in a short period of time, 2 to 3 weeks. So in the vast majority of patients, you do not need also to postpone therapies.
So sometimes a procedure for oocyte or embryo cryopreservation can fail sometimes, and then it would take more like 4 or 5 weeks. And would you think that postponing treatment for that kind of long time would be needed in these patients?
I will not do that. We do not have evidence on how many procedures are safe. So I think it depends on the situation of the patient.
So for ovarian preservation, we'll recommend only one try. But what about when the patient is trying to get pregnant? So they will try to, according to your the protocol of positive trial, you can try for about 9 months. So would you keep on, do you recommend the patient to keep on trying, over and over again? Or would you recommend how many times a patient on IVF?
So, the positive trial allows patients up to 42 years to be enrolled. So getting pregnant is also an age issue. So it depends on how old you are. And the positive trial suggests that after 1 year, if you are not, if you do not succeed in getting pregnant, you need to have a fertility consultation. Of course, every patient participating in the trial was supposed to have a fertility consultation before starting. But the protocol allows you to get pregnant up to 2 years. So you can get pregnant, 1 month before the 2 years. And so you have this time to get pregnant. Because we think that if you get pregnant at, 23 months, of the interruption period, your pregnancy will protect you. This is the scientific idea. So if you get pregnant very early, you can have 2 children, like the Jewish women. If you are not so lucky, you can wait and get pregnant at month 23. And it's perfectly within the protocol.
So do you have any trouble in making the patients resume the endocrine therapy after trying pregnancy?
We don't have this data yet, but this is what of course, worries us much, because if you have if you have a child, you did breastfeed, and then you have to stop to resume, of course, to get back to endocrine therapy, which is associated with side effects, can be challenging for patients. And also to get back if you did not achieve to get pregnant. So maybe you want to keep trying and you do not want to stop trying. We don't have this data yet, but I think this is the most difficult part of the trial.
Also, the protocol says you have to resume endocrine therapy after delivery. Would there be any evidence for this recommendation? And would you consider this treatment still an adjuvant treatment or maybe a chemo-preventive treatment?
No, we consider that endocrine therapy.
Adjuvant
as adjuvant and not prevention therapy. Of course, this was difficult to decide.
I also noticed that the positive trial only includes hormone receptor positive patients. Is there a reason that you did not include triple negative or hormone receptor negative HER2 positive patients? Do you think that these patients won't be affected by pregnancy or IVF procedures?
No, but we decided to focus on endocrine therapy because these women usually have to receive 5 to 10 years of endocrine therapy. For a triple negative patient, she has to wait 6 months of chemotherapy. And so it's less relevant because, of course, prognosis is worse. So she has a higher risk of relapse. So getting mother can be more challenging because of the prognosis. But they do not have this kind of issue about timing. And for HER2 positive, they have the longest treatment is 1 year. With the Herceptin or the Perjeta plus Herceptin. So they do not have this issue of timing. So, and we usually, in all women, triple negative and HER2 positive, we recommend to wait at least 2 years, because we know that in all breast cancer subtypes, 2 years is the most risky period. This is the period when you have the highest risk to relapse. So that's why in triple negative and HER2 positive patients, we suggest to wait for 2 years because of prognosis. Because of course we do not want to have orphan children. Yeah. So we don't want to have healthy mother to get healthy patients to get mother. So, and after 2 years, they have, triple negative and HER2 positive patients did finish their adjuvant treatment. So they have no issue of timing, treatment-related timing.
Do you think that the triple negative or HER2 positive patients would have a protective effect in pregnancy that you mentioned before?
We do not know. We know, for example, and this data should be reconfirmed, but it's quite difficult because it's difficult to run a trial in this kind of population. But we know that triple negative patients who receive LHRH during chemo to preserve fertility, they have a better prognosis. We know, for example, the first evidence was from the POEMS trial. That they have a better prognosis than triple negative women who do not receive LHRH, because it seems that there are receptors on triple negative cells for LHRH agonist treatments. But of course, the POEMS trial were 400 patients, so you should need to reconfirm this data. There are some preclinical data going in the same direction, but this is just a hypothesis generating. So to get back to your question, we don't know. Yeah. We know it's not is not detrimental, but probably is not as protective as it is in endocrine responsive patients in triple negative. We should run another trial, but
and lots of patients do ask if they're not going to get recurred during pregnancy or trying to get pregnant. And I do say that, it's going to be all right. The data says it's going to be all right. You don't have to worry about it. But I'm really scared that I might meet a patient that does recur during the interruption. So do you have any experience regarding that kind of situation?
Of course, it happens. It happens, but we will see how many patients will relapse during the 2 years and afterwards. So now it's really very early. Of course, we all had this kind of a terrible experience of patients who do relapse, which is the same as breast cancer during pregnancy. So this is really a very tough situation. My personal opinion is that when a woman wants to have a child, you can say and do whatever you want, but you cannot convince her not to get pregnant. So I think that if a patient is not is doubtful about stopping treatment, I will not encourage, because it means that she's not sure enough of her desire, especially, of course, if she's node positive, if she has, higher risk disease, luminal B or something like that. So I think that if the patient does not feel sure about doing that, I will not encourage, because I think that this is not, from a psychological point of view, could be very tough to be there and to be, the balance will not in the right position, because she will. So I will try to address this to a psychologist, because it means that her pregnancy desire is not so strong. And so waiting, interrupting can be really very stressing. So I will not encourage, I will not recommend this kind of stress for 2 years, for example, or because these are also the situations where you do not get pregnant when you are too stressed. So we know very much that there are this kind of situation. You try, you never succeed, and then when you stop trying, you get pregnant. So I think this has to be addressed. And try to understand how strong is the desire and how strong is the fear of recurrence. And you need to find a balance. Otherwise, can be very stressful. Of course, we will see how many relapses, because I suppose and I assume and I know that some recurrences are there. But of course, we have early recurrences, unfortunately, even in patients who do not try to get pregnant. So this is, of course, something we see independent of pregnancy.
So I'd like to wrap it up. Last but not least, would you have a message you would like to pass on to the audience about, young age breast cancer patients and fertility preservation pregnancy in them?
Yes, I think that, I encourage all the attendees to go and to listen to the BCY Congress, because it is available on the European School of Oncology for 1 year for free. So you can listen to all the discussion we had. We had, as far as Far East is concerned, we had roundtables discussing specific issues in Far East. So it is also useful, I think, in this regard. In general, I think that can be very challenging to treat young women with breast cancer because they have a lot of specificities which are different from menopausal and elderly patients. As far as pregnancy is concerned, I think we need to listen to our patients and we need to discuss with them the data we have, and we need to be aware as specialists that there is enough evidence to not discourage pregnancy after breast cancer. Of course, you need to discuss specifically with your patients according to her specific situations, because sometimes the confusion is, I discourage pregnancy because of breast cancer. No, you need to discourage maybe pregnancy because you have in front of you a very high risk patient. So you know that the risk of relapse is so high that irrespective of pregnancy, the risk she will not be able to see the children grow up is high. So this is the reason to discourage, not because breast cancer and pregnancy do not go well together, but because of the individual patients. I don't know if I was clear about that. And so this is my message. Discuss with them, be open. I think that it is important for patients to listen. That's something you don't know. We do not know everything. The COVID pandemic it showed that very, 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 very clearly. And patients do appreciate if you say, well, I don't know. I can go and read the literature, but there are things we do not know. And so I think it's a dialogue, and you need to talk with your patients. And this is really usually very helpful.
All right, thank you for the last message. And our conversation today is going to be really helpful in the clinic. Thank you for your time today. Thank you a lot. Thanks a lot.
Thank you. It was a pleasure. And we will see each other virtually in Korea and face-to-face maybe next year.
Yes, thank you.
Take care. Bye-bye.
Bye-bye.